So I just wanted to welcome everyone to this outstanding panel that we have today, addressing disparities in community health, lessons learned from past public health crises. And boy, do we have some experts to learn from today and gain from their wisdom. And if you go to the next slide, Dawn. I wanted to mention that this webinar is part of a series of webinars sponsored by the Society of General Internal Medicine's Health Equity Commission. And if you haven't already made SGIM your professional home, please strongly consider it. It's a welcoming and lifelong learning community, road to professional advancement, and a voice for the future of healthcare. I certainly have felt a great source of professional satisfaction and growth myself in SGIM. And if you could go to the next slide. We also want to mention various resources that SGIM has put together for COVID-specific topics. Today's webinar is part of the Health Equity Commission's COVID Equity Webinar Series. And so just to mention a little bit about that, the Health Equity Commission serves as SGIM's chief advocate for health equity related interests. The Commission seeks to promote, educate, collaborate with SGIM members and beyond to dismantle structural inequities in health, to optimize the outcomes of each patient-provider encounter, and to pursue social justice, especially for vulnerable and marginalized populations. We've planned a full year of webinars, so I encourage you to visit the SGIM webpage for previous webinar recordings, including last month's webinar that was on trauma-informed care, and then the next few webinars coming up. And so with that, let us go on to today's webinar. And first, I'd like to introduce our esteemed speakers who will be discussing the topic today. So first, Dr. Ebony Price Haywood is Director of the Center for Outcomes and Health Services Research at the Ochsner Health System, New Orleans, Louisiana. Dr. Price Haywood is currently the Director and has at Ochsner Health, which is Louisiana's largest integrated delivery health system. Over the last 20 years, her research and healthcare administrative work has focused on strategies to improve health equity for vulnerable populations. In her leadership of the health system's system-wide research center, she collaborates with system leaders to design and evaluate the next generation solutions for healthcare delivery to improve the efficiency, effectiveness, and equity of healthcare, translates research into practice, and disseminates research findings to improve clinical, administrative, and policy decision-making. She first achieved national recognition for her efforts in post-disaster health service delivery redesign and health policy reform in New Orleans after Hurricane Katrina in 2005. She recently achieved national and international recognition for her New England Journal of Medicine publication entitled Hospitalization and Mortality Among Black Patients and White Patients with COVID-19. She is also a member of the Louisiana Health Equity Task Force's Health Disparities Subcommittee. Next in our panel, we have Dr. Matthew Davis. Dr. Davis is the chair of the Department of Medicine at the Ann and Robert H. Lurie Children's Hospital of Chicago and chair of the Department of Pediatrics at the Northwestern University Feinberg School of Medicine. He is also the Executive Vice President and Chief of Community Health Transformation at Lurie Children's, with oversight for the Patrick M. Magoon Institute for Healthy Communities. He holds the Founders Board Centennial Chair in Pediatrics. As a primary care physician, Dr. Davis sees patients weekly in a community-based clinic through which Lurie Children's serves primarily children on public insurance or who are uninsured. As a researcher, Dr. Davis focuses on conducting research that is designed to improve our health system and health policy and to advance population health for children and families at the community level. He has published more than 300 peer-reviewed journal articles and book chapters and received research funding as principal investigator from the NIH CDC, Agency for Healthcare Research and Quality, Bill and Melinda Gates Foundation, Robert Wood Johnson Foundation, and the W.K. Kellogg Foundation. He was recognized by the University of Michigan with the 2015 Regents Award for Distinguished Public Service after he served 2 years as the Chief Medical Executive for the state of Michigan, and subsequently also served as one of 5 members of the Flint Water Advisory Task Force that reviewed the contamination of drinking water in Flint, Michigan, and made over 40 recommendations about how to improve government processes and policies to avert such catastrophes in the future. Dr. Davis obtained his medical degree from Harvard Medical School and completed his clinical training at Boston Children's Hospital and the Brigham and Women's Hospital. He subsequently completed his training in health services and health policy at the University of Chicago, where he received his master's degree in public policy and was named an Irving Harris Fellow in Child Health Policy. Last, but certainly not least, Dr. Lurie is currently COVID advisor to President-elect Joe Biden and formerly served as Assistant Secretary for Preparedness and Response at the U.S. Department of Health and Human Services. Currently, she's the strategic advisor to the CEO and response lead at the Coalition for Epidemic Preparedness Innovations. She's also a senior lecturer at Harvard Medical School, a member of the research faculty at Massachusetts General Hospital, and professor of medicine at George Washington University School of Medicine. She served an 8-year term as Assistant Secretary for Preparedness and Response at the U.S. Department of Health and Human Services. In that role, she led the HHS response to numerous public health emergencies, ranging from infectious disease to natural and man-made disasters, and is responsible for many innovations in emergency preparedness and response. She also chaired the Public Health Emergency Medical Countermeasures Enterprise, a government-wide organization ultimately responsible for the development of medical countermeasures, including vaccines against pandemics and emerging threats. Dr. Lurie has a long history in health services research. Prior to federal service, she was the Paul O'Neill Professor of Policy Analysis at RAND, where she started and led the Public Health Preparedness Program and ran Center for Population Health and Health Disparities. She has also had leadership roles in academia as Professor of Medicine and Public Health at the University of Minnesota, as medical advisor to the Commissioner of the Minnesota Department of Health, and as Principal Deputy Assistant Secretary for Health at the U.S. Department of Health and Human Services. Dr. Lurie received her BA and MD degrees from the University of Pennsylvania and completed her residency and public health training at UCLA. Her research has focused on access to and quality of care, health system redesign, equity, mental health, public health, and preparedness. She is the recipient of numerous awards and is a member of the National Academy of Medicine. She continues to practice clinical medicine in a community clinic in Washington, D.C. I am thrilled to be able to have this panel discussion with this group today and thank them so much for sharing their wisdom with the SGIM community. And I know as some people will still be rolling in to join, I will just recommend now, and I'll try to remind later to put your Zoom into speaker view, as we will be doing an interactive panel discussion and you'll be able to see the speakers in full view best that way. And it's my honor to serve as moderator. I'm Dr. Renu Tipraneni. I'm an assistant professor at the University of Michigan and also serve as faculty advisor for our Institute for Healthcare Policy Innovations, Policy Engagement and External Relations team. And I'm one of the co-chairs, along with Lily Cervantes, our fearless leader, in our COVID equity webinar series. So I just wanted to kick it off by starting with Dr. Price Haywood. And I'd like to really go through each of our esteemed speakers' experiences. If you could tell us about a public health crisis or crises you faced, what role you played, and how you recognized health disparities during that crisis. Dr. Price Haywood, please share your experiences.
Thank you for that wonderful introduction. I'm honored to be here tonight. When you all first asked me to speak, I was sort of, I have to say, a little nervous about speaking, because I had to ask myself, am I going to speak about COVID-19 or am I going to speak about 15 years ago with Hurricane Katrina? And the relevance of that decision was that when COVID-19 hit, the first thing that most of us who were working in the city of New Orleans back in 2005 got really, really nervous. And that said to me that there was some PTSD that we've been dealing with 15 years later after having dealt with Hurricane Katrina and the aftermath of it. So I'm gonna go back 15 years and tell you the story. I think a lot of what we went through is relevant to today, but there are a lot of things that are happening now that we did not have the kind of support that you're seeing in this area of health disparities with COVID-19. So, you know, that was August 29th, 2005. I had just came back to New Orleans 2 months prior to that at Tulane University as associate program director of the ambulatory training. And at the time, all of our training for programs are based at the State Hospital in downtown New Orleans. That is a hospital that was dedicated to the medically underserved and uninsured for decades. I was born in that hospital. Most of my family was born in that hospital. There's a very deep connection there from that standpoint, but also from training. I did not train there, but it is something that a lot of physicians here are tied to because of graduating from LSU and Tulane. But that was all destroyed. And so my job was to come back into the city 1 week after the storm and try to set up clinics that our residents can rotate through, because we were about to lose our accreditation because of not having anywhere to work. With some residents, we set up 6 ad hoc sidewalk clinics. Honestly, we commandeered some buildings, so I learned how to pop a lock. Don't tell that to anybody, but it was part of what we did to establish services to take care of first responders, people, contract workers, and people who had never left the city. Develop relationships with the military that set up MASH units, ended up getting supplies from them. At these locations, we set up urgent care services and actually converted them into an ambulatory block rotation for our small core of 30 residents that were back in the city since there was nowhere else to work. But the painful experience about that was just realizing how disjointed and fragmented the healthcare system had been. When people were coming back into the city after the storm, no one could identify a primary care doctor. They couldn't tell you their medical history or what medications they were taking. People with advanced complications of chronic conditions, breast cancer patients who we were diagnosing on the sidewalk, and with nothing we could do about it, right? And while people often brag about inner city hospitals being a great place to train, in my mind, it was terrible for preventive health and chronic disease management. And that was just exacerbated by there being no place for people to go after the storm. The governor at the time in the state put together a task force called the Louisiana Healthcare Redesign Collaborative. And their focus was trying to address all these things that we were seeing on the front lines. And they came up with 4 principles, one of which was to expand more affordable healthcare coverage, right? So as I said, all the uninsured Medicaid population are concentrated going downtown, regardless of where they lived in the city. We also lost all of our medical records. In 2005, we did not have widespread electronic medical records. So we were starting from nothing. And so part of the strategy was to promote the use of technology before that came through with meaningful use and everything under the Obama administration. It was also at the time when NCQA started pushing the concept of a medical home and certification. So that was implemented or put as one of the principles. And then the final piece was obviously we needed to have shared quality across the systems. Given all of the horrible things that we were seeing, we had to question if Louisiana is always 49th or 50th in the country for decades, there's a reason for that. And apparently we're not addressing it very well. So although this didn't get national attention, this was something that we were dealing with locally from this long history of, I have to call it what it is, but in my opinion, it's a form of structural racism where the state was funding the state hospitals for uninsured and not giving people a choice of where to go with the money following them. And as a consequence, when that system was destroyed, those were the people who were affected, right? Mostly African American. So we had to do a whole lot of health policy work while trying to be physicians, while trying to be educators at the same time. But the bottom line is we needed money to do what we needed to do to meet these principles. And a group of folks across different healthcare sectors got together and actually went to DC. And they actually testified before Congress and talked about all these things we needed to do and what our experiences were. We had legislators come down. I mean, Newt Gingrich actually visited, came through the clinics and stuff that we had. And they were impressed by what we were doing. And at the head of HHS also came down to see what we were doing. And the next thing I know, there was a $100 million grant that came to the city from CMS for us to do all these things that were discussed at the level of the state, all right? And so that was called the Primary Care Access Stabilization Grant. And the purpose behind that was to expand federally qualified health centers in the area to shift the care from the acute care setting, which everyone's traditionally used to, because our economy is service industry, low income workers, uninsured. So the hotels, the restaurants, and all the stuff in the French quarters that everyone enjoys, those people don't have insurance. And so the idea was to develop an infrastructure around them to shift the care out to the community. And, you know, Tulane University at the time, we actually set up shop in a homeless shelter for kids called Covenant House, New Orleans. And they gave us a boys' dormitory, which is a 2-story building that we converted to a fully operational primary care clinic that was funded by money from this CMS funding. We also operated mobile units, developed a consortium, and also developed clinics in non-English speaking neighborhoods for our large Vietnamese community. We also, as a result of that work, and we're pushing the message about we can't go paper-based. We've already lost everything. We started having initiatives around electronic medical record, some of which at this time, once Obama was elected, came through the ONC, and there were these beacon community grants. And so that allowed us to focus on not only establishing the electronic medical record, but also starting to talk about transitions of care issues and health information exchange between these clinics and, you know, the hospitals that were rebuilding the safety net. I do have to say, disappointingly, after all of that, that instead of us shifting the system around so that people could have a choice of where to go for their care, we essentially kind of rebuilt it, but then said, okay, instead of you going to the emergency department, we want you to go to just the federally qualified health centers, as opposed to there being money allowing you to decide where you wanted to go, what was convenient for you. And although these FQHCs are in the neighborhoods, they don't provide all of your care. They don't provide your specialty care. And so you would still have to travel. If you lived miles away from downtown, they still would have to travel downtown because the money from the state was only funding select facilities to provide the care for this population, which meant that your wait times for colonoscopies and all the rest of that stuff that people needed, specialty services for those who were lost to follow up as a result of the storm, we had to deal with a lot of that. And to me, that was just a complete nightmare. So let's fast forward 15 years and here comes COVID-19 and everyone's saying, oh my, we have disparities. And my response was, this is not new. It's been going on forever. All you do is put a Band-Aid on the problem and not address social determinants of health and all these things that are upstream of the hospital and the clinics, and then expect that things are going to be different. But guess what? 15 years later, we're still at the bottom of the health rank. So clearly focusing on clinics, hospitals, is not the solution to the problem that we saw, but the hurricane itself, because it destroyed that system that everyone in this state had become, it was just ingrained in your mind. You don't have insurance, you have Medicaid, you go here, even if you have to take 5 buses to get there, that's where you're supposed to go, take a day off from work because you never know how long you're gonna have to wait. It was just the mentality that was built into the system that has everything to do with state legislature and funding. The downstream consequences of that, things that are related to your housing, your income, just all sorts of things that complicate the picture of why people walk around with chronic disease. And then it just gets exacerbated when there are these disasters and public crisis. I will say to everyone that the next time I hear anyone say that a hospital is a good place to train in because you see, quote, great pathology with the patients who are in these facilities, my response to you is that means that you don't do a good job with public health. So it's probably not something you should brag about when you're recruiting people to your program if that is the selling point. And I'm saying this because that was the selling point for the charity hospital system. If you meet people who trained at LSU and Tulane, they will talk about charity hospital. I didn't train at Charity Hospital. I was born at Charity Hospital. That's why I didn't train at Charity Hospital. So I will stop there because I know I've gotten to my time limit. Happy to talk more about that a little bit later, but that was my story with Katrina and definitely has a lot of relevance to today with COVID-19.
It certainly does. And Wow, thank you so much, Dr. Price Haywood. We'll be coming back to you in a moment, but let me just share how struck I am by just how many things you were working on during Hurricane Katrina. And I just have this, oh my goodness, you sound like a superwoman, immediate reflection. But I'm going to shift for a moment so we can hear Dr. Davis's perspective. And I wanted to ask you the same question, Dr. Davis. You know, I wanted you to tell us about a public health crisis or crises you've faced in the past, what role you played, and how you recognized health disparities during that crisis.
Thanks, Dr. DiPernini, and thanks for the invitation to be part of this evening's panel with my esteemed colleagues here. Dr. Price Haywood, I'm actually going to say you inspired me to actually start my story a little differently than I anticipated with your description of your response to Katrina. So I'm going to wind the clock way back to a time when I was a medical student working in Guatemala, in the highlands outside of Guatemala City. And I was working with a Guatemalan medical student. We were providing primary care and public health in 3 different villages. And one day the health commissioner for the district, essentially the county, came by in his pickup truck and gave us a couple boxes full of suero, or IV fluid, 48 bags. That's all he had for us. He said, cholera is coming. Turn your healthcare center into a 24/7 cholera treatment unit and good luck. And sure enough, cholera came 48 hours later. And there were 46 patients we had the first night, and we lost 40 of them. And we were almost out of IV fluid by the next morning. And we realized there was no possible way that we were going to healthcare our way out of this. So we put our heads together and came up with a plan, which was to have sandwich bags with 10 cc's of Clorox bleach in each of them. And then we teamed up with the local youth group at the one church in town, a town called Cruz Blanca, White Cross. And the youth group would then walk the paths through the mountains to the homes where the families needed the bleach to protect themselves, because none of these families even had enough money to buy firewood. They couldn't boil their water to protect it. They had to bleach it. Because the disparity there in those highlands was a disparity against the native populations. They were the ones who were left out. People who had a car or a truck, the people who had a business in the town, they were going to be more protected. They might even have a gas stove in their home, but it was the native peoples who really needed our help. And so the exciting end of the story is that 72 hours later, there were no more patients in our facility. We had successfully done what we needed to do to prevent the spread of cholera. I was giving a talk about this recently to some medical students who realized for the last 30 years, I've been trying to capture that degree of preventive health success in what I do. So fast forward now, and I did a few things that Renu mentioned earlier, and ended up after a term of service in public health, following the lead of people like Dr. Lurie, trying to combine a research career with a service career. I found myself back at the University of Michigan, but then I was invited to be part of the Flint Water Advisory Task Force, which was set up, I think, in a very smart way as a bipartisan. I was not one of the partisans, I was a subject matter expert, but a bipartisan task force to take a hard look at all that had gone wrong in Flint and make recommendations. And what I learned there is that the disparities in Flint were clearly, and from day one, all about the fact that Flint, as a majority minority, and that's not stating it clearly enough, it's a 95% African-American city, had been entirely ignored in terms of the health impact when the people in power decided to change the water supply from, actually, ironically, water from Detroit, which was safe, well-treated and safe, to the very unsafe water of the Flint River. The reason that decision was made so cavalierly without regard for human health was the demographics of Flint. How do we recover from that clear structural racism and environmental injustice? That was the charge that we had to take care of on our Flint Water Advisory Task Force, because we weren't going to be empowered or even funded. We had $0, zero. We were empowered to make recommendations. And our charge to ourselves, the 5 of us, was to try to make those as practical and as health restoring as possible. We didn't want to create a series of recommendations that were somehow going to end up on a shelf and never be looked at again. We wanted instead to have them be posted on a sheet on somebody's wall or on the internet and have people check off the boxes. Are we doing enough to right the wrongs, to address the injustice, and to make sure this never happens again? That was our measure of whether we're going to be successful. What was a remarkable part of that experience for me as a health professional was trying to understand a lot of the environmental and toxicology aspects of what had gone wrong. In other words, the health impact was so far literally downstream that we had to go back upstream to find what were going to be the most appropriate solutions. And it was another lesson, a lesson that I see us embracing more and more strongly now in our healthcare discussions about how healthcare is so often too late. And unless we think much earlier, not just about social determinants, but about social needs and social context, we will inevitably show up with too little, too late, and too much harm that's been done to the populations that are least prepared to face it. So time will tell, history will tell whether we were practical enough in our solutions. I'm proud to say that the state of Michigan and the city of Flint and the county of Genesee have done several things that we recommended, but ultimately it takes political will over a long period of time. Like you said, Dr. Price Haywood, it's the same stuff wrong in 2020 that was wrong in 2005. We have literally failed our populations time and time again. So how do we have a different outcome this time now in 2020, when in an exhilarating way, we have more energy focused on addressing racial injustice in meaningful, lasting ways than we've ever had in my lifetime. And I sense we have more than a moment, we have a time, we have a period, especially with a change in the administration in Washington, to potentially do things differently in a more lasting way. But we can't pin our hopes on what may happen with a single administration in Washington. It has to be local as well as national. It has to be health as well as social. And fundamentally, it has to be about a movement that everybody feels they're part of, rather than left to some people who are asked to address a problem. So thanks, Dr. Price Haywood, for in fact inspiring me to think way back when. I realized I have bookends of water contamination as my public health areas of focus, which, if you think about it, what an incredibly old public health problem that we continue to face. We certainly continue to face it on the global scale. And we have unfortunately continued to face it on the local scale in the US as well. So thanks again for the invitation, and I'll turn it back to you, Dr. Tipanani.
Thank you so much, Dr. Davis. I was really struck by your connection of water, the safety of water throughout this story. And the fact that you talked about this it's a tale as old as any public health story. I was thinking as you were talking about the sandwich bags with the bleach about Jon Snow and shutting off the water pump and the origins of the cholera and public health story. So many things to unpack here, but we'll come back to this. And I wanted to shift to get the perspective of Dr. Lurie, who has also had quite a lot of experiences with public health crises in the past. So Dr. Lurie, I invite you to share with us either your experience with one or several public health crises you faced, what role you played, and how you recognized health disparities during that time.
Well, thanks. And I'm just so moved and inspired by both of these terrific talks. And it's made me also want to rethink about where to start. But I think because the moment that we're all facing together is so bearing down upon us, I will probably start where I thought I would. So I got to HHS as the Assistant Secretary for Preparedness and Response just as the H1n1 pandemic was starting. And obviously had a number of responsibilities there. But one of the first things that I really struggled with was trying to understand, well, where on earth were the data that could tell me anything about the status of this epidemic? The data that came from CDC were really, really late. And a lot of the analysis was pretty simplistic. And I was at the time, even at the beginning, quite worried about racial and ethnic disparities and didn't necessarily have a really great way to address them or to even know how much they existed. Because of my prior work at HHS, working with Dave Satcher to launch the Disparities Initiative, and then working really hard to say you can't do this without data and what gets measured gets done, I knew that we had built a number of systems into CMS and with Medicare data that would enable us to understand something about what disparities might be there. So I went to an old colleague in CMS. We talked about what to do. And after a relatively short time, he started producing a report for me every week on hospitalizations and deaths from influenza by race and ethnicity and by region of the country. And so you could see pretty quick that flu hospitalizations and deaths were not, equal opportunity killers in any way, shape, or form. Over time, he refined those data so that we could use data that instead of being 6 weeks old and based on adjudicated claims, we're about 48 to 72 hours old because the fudge factor between 48 and 72 hours and 6 weeks was always pretty stable and you could pretty well estimate what it was. And although it wasn't perfect and it wasn't perfect enough for our colleagues at CDC, it was good enough for me to know that the disparities were there. They weren't getting any smaller and that we needed to do something about them. So we then started to build into that vaccine uptake. And we worked with the AMA and the CPT people and all this stuff to get CPT codes for administration of flu vaccine. This will all sound really familiar. Administration of flu vaccine, because although flu vaccine was going to be administered for free, doctors, clinics, anybody who was going to vaccinate would charge for them. And so they needed a billing code. So all of a sudden you had a billing code attached to receipt of influenza vaccination. And you had a system that could look at vaccine uptake for Medicare recipients around the country by region of the country, by week, but importantly by race and ethnicity. So it was really, really important for us to be able to get an early handle on when race and ethnic disparities were occurring, where they were occurring, and start to really push that information and work with communities on the ground to see what it was that we could do something about it. My friend Bruce Gillen, who used to run the National Vaccine Program Office, summarized what we did very aptly. We did the same thing, only louder. Louder doesn't work really well. And while in some areas where communities got really involved, we could make a dent in these disparities, we as a country and as a government really struggled with how not to do the same thing, only louder. And I think we are about to face that challenge again. So one of the incredible frustrations for me, one of the many of watching this whole COVID thing unfold, is that system from the beginning of H1n1 in 2009 until today produces a weekly report for my former office and for my successor with flu hospitalizations and death, COVID hospitalizations and death by region of the country, by race and ethnicity. And they deny that it exists. What do I take from that? It's really important to vote. And I think we all came to understand that in a very profound and visceral way. So we will get that system back and we will put it to good use. But as Dr. Price Hayward said, no surprise here that these disparities exist, that they persist, and the denial of them. Talk about structural racism. This is structural racism foisted by our federal government on our people to deny that they exist and to deny that the system is there to look. So I'll just try to be quick here and say I moved a little bit from there to realizing that CMS data had a lot of power to deal with a number of other disparity populations. And so for me, one of the other so I had to manage through all kinds of hurricanes and tornadoes and floods and you name it. And in every one of those things, a population that consistently got into trouble were populations that were at home with electrically dependent medical equipment. And if you had a good support system before a storm was coming, you would go move to be with your family. If you didn't have a good support system, or if you didn't have the money to move, or if all these other things happened, you would get flooded out. Somebody would come get you. They'd pick you up with all your 6 or 8 pieces of medical equipment and take you to a convention center, a gymnasium. Sometimes you would go to a shelter where you blew all the circuit breakers and were really humiliated because they couldn't sustain all your medical equipment. And from there, you would wait out the rest of the storm, some of the aftermath, and then often you deteriorated enough so you couldn't go back home, so you'd go to a nursing home. It's a really terrible thing. And again, these populations were disproportionately minority. So building on this experience from flu, I said, well, gosh, you know what? I'm guessing that CMS buys the bulk of this medical equipment because it's either people who are disabled or people who are elderly that have it. Lo and behold, they buy 85%. And sort of never taking no for an answer, we ended up building a system to say, okay, health departments, you can no longer tell me you didn't know these people lived in your community because you couldn't see them. You can no longer tell me they only come out of the woodwork when the power goes out. I'm going to make it so you know. So CMS data now gets run every month for all these different subpopulations. You can go on a website, you can look on a map and see how many people with different kinds of issues live in your community. So you can never again not know that they exist. And a health department, if it wants to, when a storm is coming or if it's passed or whatever, can email or call HHS and say, can you give me that list of people by name and by address, personally identified information that they can HIPAA protect, and they can go get them out of harm's way. We tested this system at the very beginning in New Orleans, going door to door, talking to people, making sure people really had the medical equipment that was in the claims data. It was about 93% right, which was good enough for me. And the only people for whom it was wrong were people who died in the last 48 to 72 hours. So that was pretty good. So where does this take us to now? We can right now, in fact, we have on the outside, build a predictive model for COVID hospitalizations and deaths. We know, and you can build it so that it incorporates not only the kind of standard stuff that CDC has and diagnostic codes, but in fact, you can use the components of the Social Vulnerability Index to build that predictive model. So we've done that. You can identify the highest risk quartile or the highest risk quintile. If you were a different administration, you could now put all those people on a map Every health department in the country could know how many of those kinds of people lived in their communities. They could plan for a vaccination campaign. And indeed, they even could have their names and addresses. And in fact, if you had voter canvassing software, you could be really efficient and just go around and vaccinate all those people in their homes. So that's a little bit, I think, of the potential of where we are now, of the tragedy of this administration for failing to act in so many different ways, but potentially offer you, all of you who are sort of at the front lines of helping your communities figure out about vaccination, where you want to go. End-stage renal disease patients and Native American populations are numbers 1 and 2 on that list. There is already a map of ESRD patients. There's already a map of oxygen-dependent patients. All of that stuff already exists on a website. Any health department can look at it. They can know how many people there are. And if they ask HHS, HHS has to give them the names and addresses of those individuals. And you know what? They can go vaccinate them and they can save lives. So I will just stop there because we're facing a moment, all of us, whether we're in government at a state and local level, whether we're at a university, whether in a community, where we're all now about to be pulling together to get this job done. And if you know who it is that lives in your community, if you understand the basic composition, race, ethnicity, what language they speak, that's on the map too, by the way. So that we could always send responders that spoke the language of the population. You know, all of those things. It's not rocket science. It's doable, and we can all do it. And it would be great to hear back from you all at the other end of this. I'll stop there.
Wow, thank you so much, Dr. Lurie. I was really struck by all the systems you built, but also horrified at how there's not being they're not being used or even admitted about their existence. That's just
That's why we have
shocking.
the pandemic, is it not?
Yeah.
So, yeah.
Yeah. There's so much to unpack here. I wanted to shift to getting all of your wisdom about how do we go forward. And some of you have already mentioned this, but starting back with Dr. Price Haywood again, I wanted to learn about what lessons you learned about addressing health disparities during a public health crisis. And if there are any pearls you can share with our audience that they can bring back to their communities, we would be really grateful. And Dr. Price Haywood, for you in particular, I was struck by how you were building the infrastructure as you went. I mean, the electronic health record, the outpatient safety net clinics. I mean, there were just so many pieces there. So how do we think about this coming into the current era with COVID, where we're seeing it again, but in a different way?
Well, I'll start with where Dr. Lurie left off, which was the data and analytics. Back in 2005, we did not have the infrastructure that we have now. But this time with COVID-19, we did. And so we were able to, within Oxygen Health System where I am now, to optimally use the electronic medical record data to do analytics when there was no community testing. And we needed to predict hospital bed, vent use, ICU capacity, and things of that nature, when everything that was being pushed nationwide was not predicting what we were seeing locally. So at this stage in our history, we don't have an excuse for not attending to collecting the data and developing the analytics that we need for whatever purpose to take care of our patient populations. The other piece is having that's allowed us to very quickly point out the disparities, which everyone kept questioning whether or not it really existed. The other piece that I started off my story with was this issue of the mental health consequence of disasters and this pandemic. And if there was any one thing I want people to take from this, is to always attend to the impact that has on your frontline workers, in addition to the community that's impacted by whatever this pandemic or disaster happens to be. Like I said, a lot of healthcare workers the level of anxiety when we were told to shut down by the governor, everyone freaked out because they had memories of what happened back under Katrina when people died in the hospital when everyone was left, flooded in. But we still deal with that mental health consequence 15 years later. Now it's being compounded by COVID-19. So if you don't attend to that, provide support services for your staff, your physicians and other healthcare workers, burnout is real. And you've seen stories of people who have committed suicide as a result of that. And that's because no one's attending to their needs. And if we can't take care of ourselves, we're not going to take care of the community. You can just forget it. Okay. The other piece I'll end with is, the importance of community engagement. And in this case, dealing with COVID-19, I think a group of us were speaking earlier about the importance of who's the messenger around vaccines because of the historical medical mistrust for very good reasons. And now on top of that, you've got science that's been politicized. So now whatever progress we made, we have to start all over again. But to gain the trust, it's not going to be the healthcare system because the healthcare system is part of the victimization of the population. We have to develop relationships with credible community groups who can then be the voice of whatever we are trying to achieve. You had mentioned earlier, it seemed like I was doing a whole lot of stuff under Hurricane Katrina. I want to point out that was not alone. That was with all the community support and people coming together with different resources and skill sets to mobilize things in such a way that we could move forward together as a community. But you can't do it by yourself. I don't care how big your organization is, how powerful you think your organization is, you'll never do it by yourself. And so you have to engage the local community. And the last piece I want to say, and I'll stop here, is the role that we play in health advocacy, the importance of your voice as a physician, the patient stories that you bring to the table that make everything tangible. I think we're put in a privileged position and we do have to fight the fight, and we bridge multiple worlds and we're the experts. And I think we undersell ourselves, we undersell our expertise. We don't give ourselves credit for all that we can do for the community. And I think these are the times when most of us just step up because you are capable of doing it. And you do have the skill sets and the expertise. We just have to trust in it, work together and get it done. I'll stop there.
Thank you so much. And Dr. Davis, I wanted to ask the same question. If you could reflect on what lessons you learned about addressing health disparities, whether it was in any of the public health crises you mentioned, and if there were any pearls you could share with us so we can bring those back to our communities. And one thing I'll say that I was struck by when you were talking about was kind of repeated failures. How do we prevent another repeat failure?
Thanks, Dr. Tipernini, and Dr. Price Haywood emphasized two critically important parts of any effective response: the attention to behavioral health, which I think actually in the middle of COVID-19, I think we're actually doing a better job of at least being aware. The response will be another thing entirely. And then community engagement, which is going to be essential. And I think we're all touching on that tonight. I want to describe a couple of evidence-based stories that for me are motivations around bold leadership that's necessary in times of disparity. You have to call out and act on the disparity. And these are both bits of evidence I've collected along my career. The first happened when I was asked to serve in state government, and I asked my boss, the head of community health, what I should be focusing on. And he said, #1 problem in Michigan, racial disparities and infant mortality. Do something. So I'm, like my co-panelists, I'm a data person. And I went to national data, state level data. What states have had the most impact on reducing disparities in infant mortality and improving infant mortality over a 20-year period, over a full generation? First thing I found, the states that made the most progress were the states that made the most progress on their disparities. In other words, disparity is not a separate problem. Disparity is the heart of the problem. Second, the state that had made the biggest jump was Alaska. Alaska had gone from worst to first. What was that about? Well, it turned out the disparity in Alaska was like the disparity I found in Guatemala, the disparity between the majority population and the indigenous population. They actually had a great network of single propeller planes that would bring moms who had given birth to premature, often low birth weight babies from remote villages to Anchorage. But you know that's going to be too late. We can't healthcare our way out of that. So what Alaska did, they knew they had a massive problem. They were worst in the country. So they decided they were going to identify all women. This is back to Dr. Lurie's MAP idea, or MAP execution on the idea. They knew where all the women lived who had had a previous premature birth. That is the #1 risk factor for another premature birth. Doesn't take a rocket scientist to identify that mom as at risk. And they brought all those moms with their spouse or partner to Anchorage and put them up at the Red Roof Inn, just down the street from the University Hospital. The Red Roof Inn. And when the legislators in Alaska found out that Medicaid dollars were used to spend money on Red Roof Inn for the last 12 weeks, 14 weeks, 20 weeks of pregnancy, they were outraged until they found out what 1 day in the NICU costs. That bold leadership to address a definitive disparity took Alaska from worst to first. I recently testified about infant mortality and maternal mortality in Illinois, where we're not making enough progress and we have persistent racial disparities. And I said to them, I want Illinois to be the next Alaska. I want us to have such bold leadership calling out disparity that we will not turn back on this problem. And a shorter example from the federal level of decision-making comes from the Advisory Committee on Immunization Practices. I am looking for the ACIP this week for COVID-19 vaccines to be as bold as it was, calling out disparities for the pneumococcal conjugate vaccine for children in the year 2000. There was debate at that time among the members of the ACIP about whether their recommendations for the first time should call out a racial and ethnic group as particularly high risk. We knew the data. We knew that children and adults in the African American community were more likely to die of pneumococcal pneumonia, period. Incontrovertible evidence. So why not make a recommendation highlighting the importance of vaccinating African American children when we knew data again that African American children were about 10 percentage points less likely to be up to date on their routine immunizations? The ACIP did the right thing. They called out this particular risk group, and lo and behold, 18 months later, I got a chance to write an accompanying commentary on a paper from the CDC that showed pneumococcal pneumonia rates had gone down among children, but not only among children, among African-American children especially, and not only among African-American children especially, among African-American seniors who never got the vaccine. They were protected by their grandchildren. Not only that, but pneumococcal conjugate vaccine was the first vaccine to not have a racial disparity in its administration. That's what we get when we have bold leadership that calls out a disparity and sets a clear action plan.
Thank you so much, Dr. Davis. And Dr. Lurie, you could finish us out with lessons you've learned from your experience with various public health crises. What pearls can you give our audience so we can bring back to our communities? How do we address health disparities at the same time that we're addressing this current crisis?
I think that Dr. Price Hayward and Dr. Davis have said it really well. I mean, you got to be in the community. You got to listen to the community, right? You need trusted messengers. And for those of us who do community work, once you make that commitment, like you're there for the long run, you don't cut and run. So I just want to say that for those of you, especially in academic careers or others, I think it's a really, really important thing to know. Secondly, the set of issues about mental health for me for any crisis have been absolutely profound. We heard about them very poignantly from Dr. Price Hayward. I've heard about them from others, but they've complicated anything I've ever done. The third thing, and we heard again from Dr. Davis, you got to keep your eye on the data. You got to be sure it's there. Even if it's hard to generate, you got to get it. You got to get it in front of people. You got to not stop measuring, but it's got to be paired with faces, with stories, with advocacy, with really compelling pieces. You don't take no for an answer, ever. If you need to get to yes, there's always other ways to get there. And I guess what I'd say for all of you who are sort of building programs, places, and I think Dr. Price Hayward said it very well, it can't depend on you. If you disappear, it's got to continue. If something happens to you, you get thrown out of office, whatever it is, there need to be people who are going to carry that torch. And part of putting in place a successful intervention and maintaining it is putting in place, I think, that level of sustainability. The last thing I might just say about that is for my entire career, from the very beginning when I started working on these issues to now, there's been one constant that's really sustained me other than what is inside of me, and that's SGIM. And that is the community of people that is SGIM and the generations of people that help one another along. And so I was really moved by your comments about that. It remains my professional home. It's why, 7 o'clock on Monday night, we're on Zoom, right? Because this is a community, I think, that is really important for us. So count on it, lean on it, carry it along, and help develop both the next generation. And for all of those folks who are sort of tired and worn out right now, just give them a little support.
Thank you so much on behalf of our whole community. And I really wanted to, while we're transitioning in a moment, I wanted to invite the audience to start thinking about their questions and either posting them in the chat, or in a moment I'll call on you if you want to unmute yourself. But I just wanted to reflect on just some themes that we've just heard this wisdom from Dr. Price Hayward, Dr. Davis, and Dr. Lurie about lessons they learned. And I just couldn't help but jot down notes because I want to save this forever. We were talking about the importance of data, but not just data plus stories that illustrate what's happening, how we need to continue to call out disparities and take action. Data, including looking for positive deviance. We heard about look to examples where it's worked out, like in Alaska. Couldn't underscore more the discussion around community engagement, really looking to the community for what should be done. This isn't about healthcare, this is about health, and seeking out trusted messengers and really longer lasting relationships than just one crisis at a time. We heard about physician advocacy, how strong our voices are and how we often undercount that, but really need to speak up in times like this. I'm so glad we talked about mental health for frontline workers. I mean, I think we're all exhausted right now, not just because of the late hour, but it's been a long year, and I really appreciated how important it is to pay attention to that and to thinking about SGIM as a source of replenishment. At least that's how I've felt often during this year. And then I just really wanted to close with saying I really enjoyed the lesson learned about it's not about an individual, but it's the whole team, the collaboration, and across the community. And of course, being at the University of Michigan, I can't help but thinking about our famous football team quote, the team, the team, the team. And so I just wanted to close with saying this is just a wonderful community to be part of. And I'll look forward to hearing from the audience if there are any other questions that we wanted to discuss.
I have one quick question. I'm in Colorado, and in Colorado, specifically in Denver County, COVID-19 has disproportionately affected the Latinx community, especially the undocumented immigrant community. In Denver, at least, they represent about 29% of the population and about 60% of those that have cases hospitalized, and I think even slightly higher deaths, something like 62 or 63% of deaths. And my question is, I'm very active in the community and in advocacy, and for the past couple of months have been reaching out to Denver Public Health, CDPHE, our public hospital, to try to improve communication with the Latinx community, because what I've heard from hospitalized patients is that there's a lot of misinformation. They're not, many of the patients, mixed information, but some of them thought that this was the government's way of getting information to deport them, a lot of distrust. And anyways, the trouble I've had is in bringing the various groups together to improve communication for this community. We started to get some momentum as we worked with one of our largest community stakeholders. And then all of a sudden, two groups that weren't initially working together started fighting about branding on the communication launch. And I just, like, as a clinician, as a hospitalist, I felt so burned out and just wanted to throw the towel in, because it was just so disheartening, as a hospitalist, to see so many Latinx in the hospital dying, and these groups are fighting about branding on a communication launch for the Latinx community. And Dr. Davis, you mentioned sort of bringing people together, brainstorming when in a way that's bipartisan. And so this is where I was just sort of at a loss and feeling burned out emotionally as a hospitalist. Just felt like I am done. I'm angry and I'm done, but also really conflicted because I care very deeply about this community. And so any words of wisdom?
Well, Dr. Cervantes, I'll start, and then I hope that Dr. Lurie and Dr. Price Haywood will join me. We're all burned out. I'm right there with you, and this work is extremely hard on the patient care level. It's hard in the community engagement aspect of it. It's hard because our families are having to adapt so much as well. And so I feel for you, and I have gone home many evenings very, very disheartened and frustrated. And I turn to different sources of information for sources of inspiration in terms of why keep going. And we are fond of saying at our institution, if not us, who? And I think that's really part of the attitude that we have to have at our healthcare institutions. And I know that many of our community-based organizations also feel that way, especially if they are strongly grounded, not in terms of a particular service, but in terms of a particular identity. So I have found over the years here in Chicago that it's the identity-based groups that tend to have the most perseverance, I think, in some ways, because that identity is such a strong glue that is at the heart of resilience. And if you're having some difficulties with your community-based organizations around branding, or to put a more general umbrella on it, missing the point, then what I would say is try to bring the conversation around to the stories that we've talked about. You as a frontline provider yourself have stories. And those stories have stories of how they connect back to that community reality of that family who didn't have enough PPE at home, or the frontline worker who had to go to her shift because she would lose her job otherwise, etc. Those motivating stories that tell us, show us what path we need to follow together, can be a way to work past these obstacles that organizations naturally throw in front of any process. One thing to recognize with some possible exceptions on this panel, most of us haven't done this before. So the idea of trying to make our way through an unfamiliar situation is something that fundamentally connects to the problems of uncertainty. And perhaps Dr. Price Haywood and Dr. Lurie would feel similarly, but at times of uncertainty with people you don't really know, stories are a great way to connect and share a motivational moment. So I suggest, when in doubt, go back to a story.
I would agree. This issue of organizations trying to brand, I have to be honest with you, you're going to deal with that all the time. So part of it is just understanding that's what it's going to be. And if you mentally prepare yourself for the reality of what's going to happen when you go into these groups. Literally I was on a very nasty call last week. So I know exactly what you're talking about. But this idea of telling a story so that when people are discrediting everyone around this joint effort for some larger mission and some larger good, that's literally what I did. I just broke out into a story. And sometimes I'll personalize it so that to get rid of whatever threat they may see with me and my big organization coming into the conversation, I'll take it down to a level that they can relate to me and ignore all these other titles and people and organizations and stuff, and get them focused on the mission around the community. And there's ways of getting people to let go of some of that, but you have to realize a lot of it is still going to be there. And it's just with time that you learn to navigate it. But your biggest bet is if you are aware that it's going to be there and you're mentally prepared to stay strong and stay in it and not let it be something that deters you, you'll get through it. You'll probably be the one that influences the change, but change is slow and it doesn't happen as fast as you might want it to happen. So it does require some patience and resilience on your part. It's not easy at all. And I wouldn't tell you that it was easy because it's not, but hang in there.
So I'll confess that I missed the very beginning of the question and your story here because I had to get my oven turned on and have my husband say, "What? We're not eating yet." but I might just reflect on a couple of things, just building on I think both these terrific comments. I also think the stories are really powerful, and I use stories a ton. The other thing that I do is I make myself really vulnerable and I say, I need help. And I need your help. And here's something that I'm really struggling with here. And I don't know how to deal with it. And I'm quite honest about it. Because it does sort of change that whole power dynamic sometimes in a way that's really helpful. And to let them know that you're upset, that you're struggling, and that you need help is okay. I think is also just a really important thing. And then I'm also just still sort of hearing the distress in your voice and feeling the distress, seeing the distress in your face, and wanting to say, I think as Matt said, like none of us have ever done this before. This is just really hard. You're not in it alone. We all need to, as I said, sort of reach out and help carry one another through this, right? But I think it's going to be great if there are others who are sort of struggling with some of the same kinds of issues, or even other issues, that you can find some time and space to share some of these struggles, just get them out, right? And then think about the other people around who can help talk them through and problem solve them with you. And I'm guessing that both that will give you some of the strength and resilience to get through this, but also everybody will come away from this with some new ideas about how to address the problem. you can't let yourself be in this alone.
Thank you, everyone. And thank you so much, Dr. Cervantes, for your question. I think you're already making yourself vulnerable. And I know from firsthand experience what a great storyteller you are. So I'm wishing the best for your next steps. I wanted to see if anybody else in the audience had a question, in which case, feel free to unmute yourself or post it in the chat.
Hello? Hello, this is Marshall Florent. I had a question.
Please go ahead.
Yeah, so it seems like one theme that I'm hearing, I think, is that, particularly Dr. Lurie, is the availability of data at the federal level, but that not being used and having to rely on the local level to bring out, to come out with the data. I'm thinking particularly with COVID and the information coming out from Milwaukee, and Louisiana. But I'm, disappointed to hear that data might have been available at the federal level just as early as that data come out. And I'm wondering if really having some type of local level, I don't know, some kind of connection or network is what we need to kind of have a robust system when, the federal level fails us. And I just wanted to your idea on how we can have a more robust system.
Boy, I think it's a great question. And I guess what I would say is a really important thing is just to know that it's there, right? And again, I mean, this is sort of interprofessional, intergenerational learning that we're all doing. And so it would, I think the question is at this point, it would be important to know this system is there. I think there's also, even some literature, not that anybody has time to go dig it out these days, about where it is, where it comes from, how to find it, all that sort of stuff. But I think the community of people who work on these issues is, I just have always found is really strong. It's really open. And if you just pick up the phone or send an email, even to some random person who's working on these issues, chances are they're going to open it up. They're going to give you some time. They're going to help you figure out where to navigate to where you need to navigate to, and get yourself some help. And I've been kind of gratified to see, especially with COVID, I mean, those people all over the country. I think a point that you make is really important was a lot of people sort of reach out to one another one-on-one, and there's a pretty decent connected network, but there's not a really good way to see it and to know it's there other than a little bit by word of mouth. There are, as you know, a number of advocacy communities and research communities that work on some of these disparity issues. And I guess what I would just say is to start there. This problem of how you get the feds to cough up this stuff when they don't want to, or they don't want to acknowledge that it exists, that's really, I mean, I've really been struggling with that. And I will tell you, I've worked with a lot of journalists and folks in the media and folks in Congress to try to get a lot of this stuff out. And I think part of the issue with this pandemic is, every day it's a new issue. And it's really hard to kind of keep their attention and keep their focus long enough for the folks who aren't being cooperative to cough it up. But 46 days, right?
And counting. So Dr. Florent, I heard a little something different in your question, which was, how can someone like you at your institution, wherever you may be, access data like this, or in essence, turn data into power, turn data into knowledge, use your skills as an SGIM member, perhaps you have training in some data background, or perhaps a colleague does. And what I like to do is, as I'm reading the literature, I take notes of how people have put data together and what publicly available data resources they have tapped for their analyses. So I have two to suggest for you. One is, after the tragedy of 9/11, many states set up what generally come under the heading of a syndromic surveillance network or syndromic surveillance system. It's probably managed in your state by the Department of Public Health, sometimes by an equivalent of Department of Homeland Security, whatever that may be. And it's often a not very deep, but pretty broad way to track movements of patients across multiple different health settings in your state. And back where I was in Michigan, before coming here to Chicago, it was updated every 6 minutes. That was pretty awesome. So we actually were able to track individuals coming to the emergency department by age group in Michigan after we expanded Medicaid under the Affordable Care Act. So we use it for a totally different purpose, to try to anticipate the nature of what the state was worried about, which was people going to the emergency department unnecessarily, quote unquote. That's just one example. Syndromic surveillance network. Particularly relevant in the middle of a pandemic, I think. Number two, your hospital, probably in its business unit, contracts with the State Hospital Association. They're members, probably, okay? As part of that membership, they enter data about hospitalizations, sometimes day surgery, sometimes even outpatient visits, into a state level database. That state database actually then becomes national databases at AHRQ. But well before that process, which takes a couple of years, your hospital has access to state level data. Like I said, most often around hospitalizations, ER visits, sometimes outpatient surgeries. Those data are usually lagged only by about 3 months. So we've already been able to look at pandemic-specific patterns of healthcare utilization across all institutions in the state of Illinois. Those aren't widely available to researchers elsewhere. And state-level data matter a lot at this time in the pandemic, when our states are trying to plan and respond, and when our cities are trying to plan and respond. You can focus whatever question you may have on your particular metro area. So I encourage us to think about more widely available sources that may be right under our noses that don't require you to go out and collect the data yourself.
Thank you so much. If I could have another follow-up question. You mentioned the amazing turnaround in Alaska with infant mortality rates. My wife is an OBGYN and we're in Georgia. And she laments about how we're doing over here in terms of infant mortality and particularly maternal mortality and morbidity here in Georgia. And I was impressed that, you know, Alaska is a state with a legislature that's probably similar to here in Georgia in a sense, in terms of party. How I'm wondering how we could use those same tools, the story that they did in Alaska down here in Georgia, where I think it would be, you know, incredibly impactful and very important.
I think there is a lot of transmissibility of these lessons. Here's a challenge. Okay, I had to call so I found this pattern in the data. I couldn't find it anywhere reported, so I called up the Alaska Department of Public Health and I said, "Who's been there since 1990? Who could tell me the story?" And oftentimes people have been around in local public health or state level public health for that period of time that they could be a resource. And I checked my facts and I asked them for the details. I certainly couldn't see the details about the Red Roof Inn that I shared with you in the data itself. But people in your typical state departments of public health, with just a few exceptions where the phenomenal state departments of public health, Massachusetts, Minnesota, California come to mind for me, they might have some folks who are more academically inclined and want to write about this type of opportunity or have some bandwidth to do it. But most don't. And nobody in the Alaska Department of Public Health had the bandwidth to tell this story. So that's why I like to tell it, because I think the more we understand what a story like that can mean in other places, the more it can be helpful. There is a cautionary tale, an ending to this story that I didn't share because it's a little less motivating, although maybe it's motivating. So I told the story at a perinatology conference. And the head of the Alaska American Academy of Pediatrics was at this meeting. And she walked up to the microphone and she said, you know, I love that somebody told a story about my state, but I got to tell you, things have gotten worse. I said, that's really sad to hear. Why is that? She said, well, because the state set it up so that all the women at risk would come to Anchorage near the university hospital. But when the other hospitals in the state found out that the university hospital was getting all these high-risk births, the other hospitals wanted in. And the legislature changed the program. But the quality was not uniform, and the outcomes got worse.
And so, Matt, for me, I mean, that's incredibly powerful, but it also tells me a couple of other things that I think we talked about, right? You got to keep your eye on the ball. And whenever you're doing something like this, you just, you got to be sure that there are people who are going to come after you, who are going to try to sustain this and sustain the gains and keep looking. And I am guessing that even if there was somebody there now who could really pick up those reins and care and take care of that, they would be able to do exactly what you did, to use data to say to all these other hospitals, and that's happened. Look at kidney transplantation as a field of example. Look, you don't get these outcomes, you don't get to do the work. And either people get better because they want to do that and they're motivated by something, and this is a lot what quality improvement and all that stuff is about, or you use data and advocacy to make them change. And that is a lot of work that a lot of folks in our SGIM community do.
Thank you so much, Dr. Florent, for those really thoughtful questions. And I just want to really thank you from the bottom of my heart to our amazing speakers again tonight, Dr. Price Haywood, Dr. Davis, Dr. Lurie. I wasn't kidding when I said I really will savor these lessons learned for at least my career and lifetime. And I want to close with one of our SGIM community and audience members. I couldn't say it better than this comment in the chat. Thank you for this incredible session. I have been an SGIMer for over 30 years, and I feel I have grown up professionally and personally with SGIM as a vital influence for me. I am deeply inspired by all of you, all of the generations. Thank you, Dr. Price Haywood, Dr. Davis, and Dr. Lurie for taking the time to gather and teach us. So thank you again. And I will give my personal applause since I know everyone else is clapping at home. Thank you very much.
Well, thank you for organizing this. This has been terrific and inspiring and just incredibly heartwarming at a moment like this, I think, when we're all struggling. And I'll speak for myself, but I'm guessing I speak for other speakers too. Always open to having somebody shoot an email, pose a problem, ask for advice, want to talk, do whatever. This is just what we do for one another. So
I agree. I didn't hesitate to say yes, I would speak because I think it's incredibly important. And I do appreciate, just like everyone else, I've grown up in SGIM. And so whatever little knowledge I have that I can impart to my fellow SGIMers, I am always willing and able to do exactly that. So thank you, and thank everyone for coming this evening.
I'm so happy to be a part of this, and the email's always open. It's always great to know of people who are wanting to make a difference and want to do so through and by and for this organization as well.
Thank you again. And I just want to also thank our SGIM staff community, including Dawn and Erica, without whom this webinar series would not be happening. So thank you for that collaboration as well.
Thanks, Dawn and Erica. Take care, everybody.
And good night, everybody. I hope you do get your dinner and dog walks and all the other things that need to happen for mental health preservation from here on out tonight.
Thank you all.